Arthroscopic Management of Humeral Trochlear OCDs by Xuan Yi, Eugene Eck, and Kemble Wayne from the Royal Children's Hospital Melbourne, the University of Melbourne, and the Department of Surgery, Monash University. Our patient's a 13-year-old gymnast with 18 months of painful crepitus which has not responded to non-operative management. Her x-rays demonstrate a pseudo-intercondylar notch sign which is characteristic for a trochlear OCD. Her coronal MRI scan demonstrates a lesion just lateral to the apex of the trochlear groove, which measures just under 9 mm in diameter. This is in keeping with the size and location of a typical trochlear OCD. Her sagittal MRI demonstrates a lesion centered 190 degrees as measured from the anterior humeral line. Again, this is in keeping with a typical trochlear OCD, making it hard to access without an olecranon osteotomy. Atypical lesions lie more peripheral and are thus more easily accessed without ulnohumeral joint arthroscopy. The patient is positioned laterally and the following portals are marked. We use two accessory portals 2 cm proximal and distal to the soft spot portal. The soft spot portal itself is not utilized for this procedure. A varus force is applied to the elbow by the assistant. This is the key maneuver to accessing the ulnohumeral joint. The KY is driven in the transolecranon fashion to microfracture the subchondral bone. With the KY preloaded in olecranon, the elbow can be taken through a range of flexion and extension to access the entirety of the lesion. Arthroscopy is commenced in the posterior lateral portal. The radial head is to the bottom right for reference. In its anatomical position, the ulnohumeral joint is highly constrained and no access is possible, as demonstrated on the left. A varus force is applied by the surgical assistant which hinges open the ulnohumeral joint. A probe is inserted and the OCD lesion is probed, keeping in mind the preoperative planning. It is evident by the softened cartilage overlying the abnormal subchondral bone. The abnormal cartilage is easily lifted and a blush of blood is confirmatory of the correct location. The OCD is then debrided with a series of sharp, curved curettes and a bullet-tip shaver to establish a well-contained defect and to minimize damage to the surrounding normal cartilage. Here, a bleeding base is seen and abrasion chondroplasty is performed. Transolecranon drilling is then performed by entering the K-wire through the olecranon just beyond the tip of the arthroscope. Fluoroscopic confirmation demonstrates that the KY is in the correct position and is advanced past the subchondral plate. The elbow can be taken throughout a range of flexion and extension to access the entirety of the lesion. Fluid is then drained and back bleeding is evident with the tourniquet on. A final debridement of any loose debris is performed before biological augmentation is used at the surgeon's discretion. In this case, we use joint rep. Postoperatively, the patient is placed in a sling and is allowed to commence gentle range of motion as soon as comfort allows. We do not restrict our patients from moving their elbow, although we do restrict loading until 6 weeks post-surgery. Sport is commenced at 3 months post-surgery. Thank you for watching.